Good morning. My name is Dr. Stuart Williams, and I'm with the Department of Osteopathic Manipulative Medicine here at the University of North Texas Health Science Center in Fort Worth, Texas College of Osteopathic Medicine. And I've been privileged to be given the opportunity by the geriatric department to participate in the Reynolds Get It program and also in the SAGE program. SAGE stands for Seniors Assisting in Geriatric Education, and they've asked me to go over an osteopathic structural examination on a geriatric patient. And as you know, being an osteopathic physician, we want to look at the whole patient, and so this exam is going to be more of a screening examination. And so we're looking to narrow down where we might want to evaluate the patient more specifically and do a segmental examination. So first thing we want to do is get an overview of our whole patient, looking at their head carriage, their entire spine. And as you remember, we've got a cervical lordosis, we've got a thoracic kyphosis, and then a lumbar lordosis. And if you remember from your, from your embryology, we're born in a kyphosis. So we are born actually this way. When we come out of our mother's womb, the first thing that usually happens is the baby will lift their head and they develop that lordotic curvature. And then as the child begins to stand erect and walk, they develop the lordotic curvature. And if you look at that, we're uniquely designed in that we're not putting the weight on the entire vertebral body down and causing problems. It's more of a spring, and so the weight moves and is distributed better in this way. So what we want to do today with our patients, which I'm very appreciative that we have some volunteers, is show you how we might have to modify that exam when we see different age groups of people. Okay, so one of the first things we talked about is we like to look at the whole patient. So I like to get an anterior view, a posterior view, and a lateral view, some of the things we taught. And one of the first things that I look at is I look at their feet, because your feet tell you a lot about what may be happening to your spine. And you can see there that she's had a surgery on her knee. Did you say you had a knee replacement? Yes, okay. And so you can see that there are some inequalities the way she's having to stand as a result of that surgery. This surgery may have lengthened this leg or shortened that leg, which could create some problems in her spine as a result from that. And also, we may notice when we have her walk that she has an antalgic gait as a result of that. Now, I'm assuming you have not had surgery on this.
Correct.
Okay, just the one on the right there. So first thing I'm looking at, if you look at her feet, you can look at the arches of her feet. And this one appears to be a little bit more flattened than the other one, and she appears to have a little bit of more pronation on this side of her foot. Now, if both of them are pronated equally, you can notate in your checkoff sheet that those are symmetrical. And what we really are looking for, do we have symmetry, do we have asymmetry, and when we have asymmetry, where do we have asymmetry? Also, we want to look at her laterally. And if you remember the little plumb bob that we had in lab, if we had a line starting, let's say we're starting right at the lateral malleolus, and we had a plumb bob, it would run just a little bit in front of the malleolus, just a little bit in back of the patella. It would come up through the greater trochanter. Then it would come up right around L3. You have to imagine that, but L3 would be right around here. Would come up to the lateral head of the humerus. Some people use the acromioclavicular joint. And then come up to the external auditory meatus. That would be normal. Now, imagining that line coming there, let's take a look at our patient. Are we able to bring our foot in just a tad there? Perfect. So if we started with the line here and it was anterior to that, we came up, we can already see that this is probably displaced a little bit. So we may have an abnormality in here or something that she has a problem with in her leg. And then as we come up, we can see now that the trochanter is going to be posterior to that line. L3 looks to be pretty level, and then we come up and see how the shoulders are coming back, which may mean that she's got a little bit of kyphosis causing that. And then you can see as we come up here, she's got a little bit of what we call anterior head carriage in those areas. So now if we turn her back anterior and get an anterior view, a few things we look for. We've looked at her feet. We're looking at her knees, and she appears, the right knee you can see looks nice and straight from her knee surgery, but if you notice, she's got a little bit of medial deviation of this knee, so she has a mild form of gingivalgum. Gingivalgus, if you remember, that is more where you have the knees in this kind of fashion. And I would challenge you that if you stand like that, you'll begin to feel the discomfort in your hamstrings, and it will gradually creep up into your SI joint. So you can imagine having to walk like that may create some problems here. So we're seeing that in her knees. We can get an idea just looking at her crest that she's going to have some unlevelness, and it looks like she has a little bit of unlevelness there. If you look at her head, she tends to rotate her head a little bit more to the right there. And then we can also get an idea as we come up, are her eyes level? They look pretty level there. She's got a little bit of septal deviation. So we're seeing some minor areas of asymmetry that we may need to focus on in our structural exam. So now if I turn her opposite, we're going to turn her, we've looked at her laterally. We also want to take note when we're looking at her laterally, what kind of curvatures does she have in the cervical spine, in the thoracic spine, in the lumbar spine? As we know, we should have a nice, smooth lordotic curve here, a kyphotic curve in the thoracic spine, lordotic curve again in the lumbar spine, and then a kyphotic curve in the sacral region. It appears that in her, she does have a lordosis. It may be a little bit exaggerated. If you're looking at it from here, it may be a little bit exaggerated. I can feel here prominence of C7, T1, T2, so she may have some forward bending that's occurring here. And she does have a little bit of kyphosis, maybe a slight exaggeration. Her lumbar lordosis appears to be pretty normal, maybe just a little bit exaggerated there. So if we turn her this way now, we're going to look at her posterior. And when I look at somebody posterior, I'm looking at paired landmarks to give me an idea now if they have a problem in the coronal plane. When we were looking laterally, we were evaluating sagittal plane. So paired landmarks, things that we've talked about in class, the first ones I would look at is her mastoid. And so as I came over here, I would want to see which side is higher than the other, or are they level? Are they level? In her case, they appear to be fairly level. She might be just a little bit higher on her left here, but they appear to be level, the left and right mastoid. And what I normally do is in my sheet, I'll just put coronal plane, put a colon. If the left is higher, I just use LM so that I know that. Then I would come down to her acromioclavicular regions and get a look, and you have to get your eyes pretty level, and you can see that this side is a little bit higher on her left than her right. And then I would just palpate down. If you can't feel her scapular border, you can bring her arm back like this and get on the angle. And I'm getting on the inferior angle of her scapula. Okay, you can bring that back. And you can see here that this one is a little bit higher on her left. And then I just gradually move down till I get to her iliac crest, which are right here. And she actually is fairly level. It's a little bit higher on the right. So you can see we're having a little bit of shifting because our bodies will try to accommodate for minor structural defects. We'll try to accommodate for them. And then we will come up and get a look now at her posterior superior iliac spines. which are right here, and on our skeleton they would be, if I can bring this, our skeleton, they would be right here. If you're having problems finding those, you would just ride along the crest, and it's almost like this little slope is made for your thumbs. They just fit right in there, and this is where I want to put my thumbs in evaluating those two paired landmarks. So I'd come over here, and there's one of them, and there's the other one. And if you look there, you can see that this one's a little bit higher than the other one, so that tells me again we may have some accommodation that she's done throughout the years because of a mild curvature. You can also just look at her spine and see there's a little bit of prominence on different sides, which tells me she has some mild scoliotic curvature. And then I can come laterally until I find her greater trochanter, the superior borders, and get a look at that. And she's a little bit higher on her right. Okay, well here we have a different subject, and we've already looked a little bit at his overall posture, so if we turn him laterally, we can get an idea of those same things that we talked about, and you can see that he has a little bit of anterior head carriage when you compare him to his lateral head of the humerus and his external auditory meatus. He's got a little bit of anterior head carriage, maybe coming from a little bit of kyphosis in this upper part, although he's kind of flattened right here. And then as we come down and we find, we can imagine where the anterior portion of L3 might be, and then we come down, and here we have our greater trochanter. So if we're imagining that plumb bob, if we started here, or we could start here with the line where it's anterior to his lateral malleolus and have it come up just slightly posterior to the patella, and it should come up here. So far, he's pretty well lined up until we get to his acromioclavicular lateral head of the humerus in here. So some of his problems may be related in this part of him. Also, he has an interesting finding anteriorly that was different from our other patient in that he has a little bit of gingivaris on that right knee, and so he has the opposite. Instead of gingivalgus, where they're more knock-kneed in this form, he's a little more this way, or what we would call bow-legged. There he has a little bit of that. So he could be getting some uneven wear and tear in that knee. Okay, so we've done a little bit of static standing evaluation, but part of osteopathy is you're dealing with functional anatomy, you're dealing with living anatomy, and so what we like to do is get an idea of what her overall gait is and get an observation of her posture while she's walking. So just have you like you're taking a stroll in the mall or out in the park, just walk towards that door and just walk back, and we'll do 2 or 3 times of that. Yes, ma'am. Yes, ma'am. And you can see that this is what I would call an antalgic gait. We'll have her come back this way. She's had a knee replacement on that right, and she sort of favors that right knee more, kind of protecting that left knee, which has a little bit of valgus. We'll have you walk again. So we're seeing that formation. Now, if you look at her gluteal muscles, notice how they drop a little bit more irregularly and a little more rigidly. I'll bring you back this way. Notice her head carriage. She tends to kind of lean forward a little bit, so she has a little bit of anterior head carriage. And we'll have you do that one more time for me. So this is a good example of an antalgic gait. And she just informed me that the knee replacement on the left has been done, and that she's had Symvis put in the right knee, which has helped, in the left knee, which has helped her tremendously. And also notice she doesn't have as good of an arm swing on her right as she does her left. So that gives me an idea of some things that I might want to evaluate for her further. So first thing we're going to do is just have our patient walk as he would normally walk if he was walking at the mall or taking a walk around the block. So we'll observe. And we'll have him walk back this way. If you notice, he doesn't have a lot of arm swing on either arm as he walks. Okay, we'll just continue. And I'm trying to see how he's accommodated to his gingivarum on that knee. Seems to favor, come back this way. He's actually accommodated quite well. He may favor that right one just a little bit. So now we'll move up and just get a look at his hip, his gluteal muscle, and see which one falls more. And it appears the left one drops a little bit more than the right one. You also get an idea, you can clearly see how this might be a little bit higher on that side. Okay, now we've seen just a couple of gaits that were probably a little bit antalgic. I wanted to show you what a Parkinsonian shuffling gait might look like, because as we mature and as we get a little bit older, we run into other neurologic diseases just from degenerative processes, and if his basal ganglia have degenerated, we may have Parkinson's. We may also have a problem with spinocerebellar degeneration, which we get as we mature. But I'd like for this gentleman to show us what a shuffling Parkinsonian gait would look like so that you get an idea. Notice how he's leaning forward, and we'll let him walk. See how his hands are kind of, has that pill rolling, and they're kind of leaned forward like they're going to fall all the time. And then we'll have him come back the other way. So this is kind of what a Parkinsonian's. Now also, you might look at his face and see if he has that masked face. See how his hands have that little tremor. That's a very good posture. So that should give you an idea that you might want to check into Parkinson's disease. Very good. And then we'd like to also demonstrate what a wide-based ataxic gait, which could be a problem with spinocerebellar degeneration. Could be he's had a cerebellar infarct. And so notice how he's got his legs far apart. And that would give me an idea that when I did my neurologic examination that I'd want to test cerebellar functions, finger to nose. I'd probably want to check a Romberg for posterior column as well as cerebellar and things like that. Okay, now we're moving from dynamic gait and we're going into a little bit more of regional testing. So what I would like to do first is just get a screen of his upper extremities. Now he's already given me a history that he has injured his supraspinatus tendon. He's had some injections to that area, some prolotherapy, see if they can strengthen that. But what we will do first, sir, is if you could just see how far you can keep pronate your arm and just bring them up as close to your ears as you're able. And you can clearly see that he's having a problem more over here. You would hope that the upper part of the humerus would come close to the ears and that these would be able to be approximated. You can see that he's got a problem here. And even if I'll hold it for you now, even if I passively bring it up, I can't come much further than that. And based on his history, it's coming from up here. Although if his arm were bent out like this, then we might have a problem in the elbow. We could have a problem in the wrist. So this tells me I need to address this glenohumeral area. But also, being a DO and we're looking at the whole picture, we would also want to address some portions of his upper thoracic spine, such as his thoracic inlet, probably T1 down to T3 or T4, as well as these upper ribs may be contributing to that. So that's just a quick screen to tell me that we need to look into some problems in his upper extremity. He may have, because he sprained this, as this heals, possibly later on he may need a 7 stages of Spencer technique to this so that we can prevent him from getting capsulitis or frozen shoulder. So we've looked at the upper extremity. The next thing is we're going to look at the cervical spine. So we have different motions in the cervical spine. We have flexion or forward bending. We have extension and backward bending. So in flexion, he should have somewhere between 45 and 90 degrees total motion. We tend to teach 90 and 90, but as we mature, we're going to lose some of that motion. And as you know, half of that motion in forward bending and backward bending comes from the OA joint, the occipito-atlantal joint. The other half comes from the lower portion of the cervical spine. So in this gentleman's case, he's got pretty good forward bending or flexion here. I would say he's got close to 70, maybe even 75 degrees of forward bending. And as we backward bending, I am getting some restrictions here. And he probably has maybe 50, possibly even up to 60 degrees of backward bending. So he has a little bit of loss of motion in this area, although he is symmetrical as I come forward and backward bending there. So next motion we would want to look at would be just side bending, just deviating their ear towards the ipsilateral shoulder. And he actually side bends pretty good. Now I tend to monitor C7 or T1 with the back of my thumb, so I have my thumb back here monitoring C7, so I know if I go beyond that, I'm getting into the thoracic spine. But he actually side bends pretty good here. This is probably close to 40 degrees. Now we come to the left, and he doesn't have quite as much motion there as he does here, if we look at that. So he's a little bit restricted. He may have maybe 30 degrees of side bending. So we see a little bit of restricted range of motion here. And then we will do some rotation. Again, I'm monitoring that C7, so if I go beyond that, and he rotates pretty good here. He's probably got 75 degrees to his left, and he's probably got about the same there. So we're looking at about 75, and probably pretty close to the same on this side, about 75 degrees. So there is our three major motions of our cervical spine. Now obviously this is a screen, and so if we find some loss of motion, we'd want to do a segmental examination when we have the patient lay supine. The next thing I do is get a look at his thoracic spine. We've already looked at it statically, and we can see that he has a little bit of a exaggerated kyphosis here. He's got some anterior head carriage that we've talked about. Now I want to get an idea of just how well that T-spine moves. So I'm going to take my MP joint, my metacarpal phalangeal joint, and place it right around the area of the first rib, which is right on that bony thoracic inlet. And I'm going to direct just a force going in this direction, kind of 45 degrees, going towards the upper group of this T-spine, which I would be imagining about T4. Also, I kind of think of maybe I'm going across towards that opposite anterior superior iliac spine. So I'm up at the base of the neck where the first rib is, and I'm just directing a little springing force there just to get an idea of what kind of resiliency he has to side bending in that upper T-spine. And then what do? We have paired landmarks, so I'm going to compare and direct a force in this manner for that upper group, and then get an idea of which one do I think springs better. And he springs a little bit better on this side, so it would give me an idea that in his upper group of his thoracic spine, he tends to be a little bit side bent to his left. That would tell me that I might need to go in further when I do a segmental eval and look at that upper part of his thoracic spine, which may be related to some of the problems he's having in his shoulder. Once I've done the upper group, you can move laterally and find his acromioclavicular joint and place your MP there, and you're going to direct the same force, which is going to get that lower group, that T9 to about T12. And so again, remember, you want to stabilize your patient. Some of our geriatric, one of their biggest concerns is they might fall, and so notice how I'm kind of stabilizing him so he doesn't think he's going to fall. Then I'm directing a force this way just to get an idea of what kind of motion he might have in his lower thoracic group. And then I'm going to come over here and do the same thing and just direct a force there. And we're going to compare those two. And he is a little bit stiffer on this side again. He resists me, and so overall he may have just a gentle side bending curvature to his left there. The next thing we want to do is take a look at the rotational component of the thoracic spine. If you remember from our classes, one of the major motions of the thoracic spine is rotation. If you remember the orientation of those facets being coronal, more coronal, as we get down into the lumbar spine, they're more sagittal, and the more sagittal would allow you to forward bend, backward bend better. In the coronal orientation, you would rotate better. So we'll have him just cross his arms in front of his chest, just like so, just like that. And then I can just take his shoulders and just gently rotate him to either side and get an idea of what kind of motion we have here. And again, once I begin to move his pelvis, if you see now his pelvis starting to come up, I've gone beyond the T-spine, so I want to stay right in this area here. You can also monitor. I can monitor with one hand in the thoracic spine, so I know I'm not going beyond that level in order to compare. I tend to just feel, and if I'm getting into the iliac crest and they're starting to move, then I know I've gone beyond that. So as we rotate him, you can see that he prefers to rotate to his left a little bit better than he does to his right. Now he also has a history of some trauma here, and that may be why he's resisting movement there, because it's pulling in his upper T-spine. But this gives me an idea that he is a little restricted to right rotation, so he has a preference for left rotation. Okay, we've done some dynamic evaluation with the patient seated. We're now going to do a little bit more in the lumbar spine, and then we're going to also look at iliosacral motion, which is different than sacroilial motion. So we're looking at the motion of the ilium on the sacrum, which we'll do with a standing flexion test. And then we will have her sit again and do a seated flexion test, which, if you think about it, you're sitting on your ischial tuberosities, and so now you would be checking sacroilial motion. So if you remember, when we look at a lumbar spine, when we talk about the facets, you can see, looking at the T-spine, these facets are more coronal in orientation. If you look here, they're a little more coronal. As you get down into the lumbar spine, notice how they become more sagittal. And you can see clearly how that would allow you to forward bend and backward bend better in the lumbar spine, which is one of its major motions, versus when you get up in the thoracic spine. If you look, they're more of a coronal. It's going to allow you to do more of a rotational motion. If you think about it also in the T-spine, because of the rib cage, all of the ligaments and all, it's going to cause quite a bit of restriction in side bending versus down in your lumbar spine. So our first evaluation is to look and see just what kind of flexion extension she may have in the lumbar spine. So we'll start first with flexion and have her go forward as if she's going to touch her toes. And I'm going to stand here and just kind of keep her from losing her balance. So we'll have you bend forward as far as you're able to go. And she can pretty well touch the floor there. Come back up. She can see in that she probably has a full 90 degrees there. It should be about 70 to 90 degrees, and this is actually quite good, and she gave me a history of doing quite a few stretching exercises. So now we're going to also have her do lumbar extension, and as we know, that's not going to be as much, and we're hoping in this that she would have around 30 to 45 degrees, so we'll have her backward bend or extend as far as she can, and I'm right here. And so she probably has about 30, 35 degrees there, and we'll bring her back. Are you okay? Mm-hmm. Okay, so now we've evaluated her sagittal plane with forward bending and backward bending. We want to look at her coronal plane for side bending in the lumbar spine. So what I will do is have her just let her, we're going to raise this up so we can get an idea of her lumbar spine, and then have her just let her left arm just kind of bring it alongside. We'll get an idea of that curvature, and then we'll have you switch to the other side, and we'll do the same thing over there. Okay, come back up. Now, just come straight to your side, just along your side, far as you can. That's probably about as far as, yes, ma'am. Yeah, you're fine, yeah. All right, now come back over to the other side. Okay, so that gives us an idea. She actually has pretty good motion in there. From there, you can just transition into your iliosacral motion. So again, I want to find that crest, and her crest appear to be up a little higher. And that's why we teach you those landmarks, then follow the crest back until you get on the posterior superior iliac spines. And I am now on them. So what I'm going to have you do now, ma'am, is bend forward again and just let your bottom come towards me, just real slow, very slowly. Keep going far as you're able to go. And you can see that my right thumb is coming up a little bit higher there. Okay, you can come back up. And so what that's telling me is she has a positive standing flexion test on the right, so that tells me that when we lie her supine, I'm going to need to check the motion of that innominate on that sacrum. Okay, so we have done a standing flexion test to check the motion of the ilium on the sacrum, and now we want to do a seated flexion test. Again, remember, these are both screens. These are not going to give us a specific segmental diagnosis, but they're going to give us an idea of areas that we need to give further evaluation. This is all a screen for us, but if he came in with lower back pain, I need to know how he's accommodated in his T-spine and in his cervical spine as a result of that. And so this is a screening test. But when you sit, if you notice, you are sitting on the ischial tuberosity, so the innominates are not moving, and the sacrum is now moving on the ilium. So this is going to test sacroilial motion primarily. And so again, my thumbs, I'm going to find the crest and ride my thumbs till I get in that undersling. I'm going to have my patient bend forward as far as he or she is able to, and then see which thumb ends up more cephalad at the end range of motion. So here we have our patient, and we've got him seated, and so I'm going to find his iliac crest and come around until I can find those PSIs. If you notice, he was a little bit more level than our other patient. Now we'll get you to bend very slowly. Just keep your arms between your legs and go as far as you can. You can see clearly this one's coming up very quickly. But I'm looking for that last motion, that last 20 degrees or so with that end range of motion. Come back up for me. Sometimes what you will see is that as you bend forward, now go forward again, bend forward, you may actually at the last part have this thumb come up, and this would be the positive. Come back up for me. But in this case, he begins rising on the right and it stays on the right. Okay, go forward one more time, sir. You can see clearly how that rises up and come back up. So that tells me that he's got a restriction on this side, and so I need to be looking primarily for sacral problems such as a sacral torsion, a right on left, a right on right, a left on left oblique axis, or a left on right oblique axis, things like that that may be causing that. Okay, we're going to do a seated flexion test on another individual. One thing I didn't mention previously, it's good if we can have their feet planted on the floor as well. When we do a standing flexion test, sometimes a tight hamstring can also give you a false positive, and so we're trying to eliminate lower extremity influences for this test. Also, I showed you that when you're sitting on your ischial tuberosities, and so your pelvis, or better yet, your innominants are not moving, so you're testing more sacroilial motion. So we're looking for those torsions, other things that may be causing her to have discomfort. Also remember hip. When a patient comes in complaining of hip, that can be several things. That could be femoral acetabular pain, the ball and socket joint, or it could be sacroilial discomfort in here, or it can be both. So if we're going to do this test on this lady, we have her feet planted on the floor, have her hands, I usually have them put their hands between their knees, and then find her crest again, get on her posterior superior iliac spines. And then we'll have her slowly bend forward as far as she's able to go, and we'll see which way my thumb prefers to go. As you can see, this is clearly coming up on the right again. Okay, you can come back up. And we'll have you do that one more time, just real slow, go forward for us. So my thumbs are kind of going for a ride. You don't want to press in so hard that you don't allow the motion, but you want to be firm enough to be contacting that posterior superior iliac spine. And you can see that mine stays on the right the entire way at the end range of motion. Okay, you can come back up. Okay, so while we have the patient supine, if we had found any abnormalities on the motion of his neck with respect to flexion, extension, side bending, or rotation, this would be the time to begin doing the segmental exam. And if you remember, your OA has half of the forward bending, backward bending motion of the entire cervical spine. So if you gently tuck his chin, you can place your fingers into the arch of the atlas, and then you can just gently untuck and tuck their chin, or backward bend and forward bend, and see if we've got a problem. He actually has pretty good motion there. It's really not bad motion, so if he has any restrictions, most of them may be coming from lower cervical problems. So then I would want to go in and evaluate those lower cervicals. We can also check the triaxial motion of the OA, which is primarily flexion, extension, side bending, and rotation, and just see, if you remember the way the condyles are set up, they tend to side bend and rotate opposite. So here would be side bend right, rotate left, and then I can simply come over and compare his other side, side bend left, and rotate right, and just compare. And he seems to be a little more restricted when I side bend him to the right and rotate him left versus side bend left, rotate right. So that gives me a quick diagnosis of his OA joint, the occipitoatlantal. Then I can gently flex him to lock out the lower C-spine, so I'm addressing now just the AA, or the atlantal axial joint. And he's a little bit restricted when we try to rotate him to the left versus the right here. Okay, so we've checked that, and then I can go further down into the other cervical vertebrae and evaluate them and treat them. Okay, so we've examined our patient statically. We've examined them dynamically while they were standing and walking. We've done some dynamic exam with them seated, and now I have the patient laying supine. And so one thing I want to assess on him is the motion of his rib cage. If you remember, these upper ribs, rib 1 to rib 5, in this region tend to have more of a pump handle motion, so they tend to move more on a transverse axis. So if you think about having a pump and you're pumping, you would have an axis this way, more of a pump handle. But as you move down, it tends to shift more into a bucket handle motion, which would be more on an anterior-posterior axis. Now remember, they can have a little bit of both, and so I want to monitor both of them, and one way you can do that is to have your thumbs along the anterior portion of the chest lateral to the sternum where the ribs begin to attach, and then have your fingers along the edge, the lateral aspects, and then we'll just have the patient take a deep breath and just breathe in and out, and I'm assessing that motion as he breathes in and out. And he does a little slow in. He lags a little bit with exhalation on his left, which means he's moving well in inhalation, so he may have an inhalation somatic dysfunction, so I need to do further evaluation in this upper rib area, more in this area, in the pump handle area. Then if you remember, we come down into the bucket handle area, and we're getting those lower ribs, those ribs 7 down to 12, and I've got my thumb to monitor anteriorly because they have some pump handle. And again, we'll have him take a deep breath And I'm feeling how that chest comes out laterally, comes back in. I'm kind of assessing my bucket handle. And he kind of lags this way here. So he may have an exhalation problem over here on his right side. All right, so we've kind of assessed his chest, and now we're going to look at him anteriorly here. So one of the first things you want to do is be sure that he's symmetrical when he's laying on the table. So what I do is just put their feet, bend their knees, put their feet on the table, and just ask the patient to raise his hips and bring them back down, set them back down. And that kind of levels his pelvis. We call that a hip flop test, a hip flop test. It just kind of keeps, raise your hips up one more time, set back down. Looks like I'm seeing a little scar here, so he may have had some kind of a little surgery there, maybe a little umbilical hernia or some kind of surgical repair that he's had done. So we're always looking.
Colonic resection.
Colonic resection, so he's had some surgery there. So the first thing I'm going to look at here are his anterior superior iliac spines level. And if you remember, the anterior, we talked about the posterior superior iliac spines. We also have anterior. Follow your crest, and it's like that little undersling is just made for your thumbs. So there you are, you're on that. And so that's another paired landmark to get an idea if there's symmetry there. Now normally I try to get where my dominant eye can be right there. And so I'm finding his crest, coming down until I get my thumbs right in there. We've had him raise his hips and lower them. And so we're remembering where we lateralized him, which he was more on the right with his standing and seated flexion test. And so he is a little bit inferior there, and he was a little bit higher on this side statically, and so he may have an anteriorly rotated innominate. So we've looked at that function. The next thing we can do very, very easily and quickly is just see how much hip flexion he has and get an idea if he might have a straight leg raise. Perhaps he has lower back pain. I want to see if he's got any radicular signs down the leg. Does that cause any pain for you? Okay, any pain as I go up a little higher? This is about as feeling tighter, but not a shooting pain down your leg. So he does have some tight hamstrings, and he's probably not much more past 45, maybe 50 degrees. So he does have some tight hamstrings, which could contribute to his lower back. We can also do Brigard's test and drop the leg just a little bit and dorsiflex the foot, no shooting pain down your leg. So,
kind of a tightness.
Okay, feeling a tightness there. So more than likely he's got some tight hamstrings, and then he may have a tight iliotibial band, which it does feel like he does on this lateral side. And then we can just repeat that over here and just see, get a comparison. He actually comes up a little bit better on this one. He might have 60, 65 degrees there. Do you get any pain down your leg, sir?
No, in the kind of the back here.
Like a tight, like a
Yeah,
pulling?
tight. Yeah.
Okay, which I can feel these hamstrings. They do feel like they're a little bit tight, but not as tight as your opposite leg.
That's right.
And then we can bring it down five or so degrees, and you don't have any shooting pain here.
No, just the tightness again.
Okay, so again, I've been able to do two things. I've looked at his hamstrings, which we've determined he's tight. He's a little tighter on this side. And I've also determined that he doesn't have any nerve root irritation in that area. So then we can progress from there. We can go in and look at his lower extremity and his hip, and one thing we can do is the Patrick test, where we do our Faber motion, which is flexion, abduction, external rotation, and extension, and just get an idea if he has any pain when we do that. Another way, they call it kind of the figure 4 Patrick, is just see if he has any pain localized in this hip joint, either anteriorly or anterolaterally, which may be the femoral acetabular. Does he have any pain back in the SI joint? And he
Very comfortable.
Yeah, he seems to have pretty smooth motion in that femoral acetabular and SI joint. And then it's good that we have two lower extremities that we can compare. So again, we have flexion, abduction, external rotation, and extension. And he seems to go pretty smooth there, and we can just place his heel gently above his knee. Do you have any pain in either in here or in the back?
No, just kind of a little bit of tightness. I wouldn't say it was pain.
Okay. All right, we can bring him back. So I can ascertain that his hips are probably not contributing to his discomfort. Okay, so we have examined our patient statically while they were standing. We also had them walk. We did standing flexion tests. We did our side bending. We did some seated evaluation. Now we have our patient supine. And so while they're supine, if we found an abnormality in their cervical spine, then we would want to do further testing. So one joint, for instance, if she had a problem with forward bending or backward bending, flexion extension, I would want to gently tuck her chin to get on the arch of her atlas and then see what kind of OA motion, occipito-atlantal motion we have. And she can untuck or backward bend very well. When she tucks, I'm getting a little bit of resistance. So she may be a little bit backward bent at that OA, so there would be a segment that I might want to evaluate and treat. I can also evaluate the side bending and rotation component of that by just gently pivoting, because if you remember those condyles, they tend to come just like your hands, like this. And so as you side bend, they will rotate based on the anatomy. And so there she is, side bent to the right and rotated to the left. And then here we come over here, and she is side bent to the left, rotated to the right. And we're comparing those two motions. Then I can come up very gently to lock out her lower cervicals to look now at the AA joint, the atlantoaxial. And I'm getting a barrier right there to the right. So she has lost a little bit of motion there. She has a little better motion to her left than she does to her right. So we may have an AA dysfunction, which we would call rotated left. Then we can go in and do further segmental evaluation on her typical cervicals, which would be the motion of C2 on 3, 3 on 4, and all the way down. So we've done that. Now I'm going to just proceed down. We're going to look at her rib cage function. She has breast prostheses on both sides, which she has removed. And is it okay for me to palpate the...
Whatever, yeah.
Okay. So what I would like to do, we talk about rib motion. If you remember, primarily these upper ribs, ribs 1 through 5, 2 through 5, that area is primarily a pump handle motion. So if you think of a pump and you're pumping, if you remember those old pumps, and you would have a transverse axis. And that's the primary motion of this area. As you move down, the further down you go, when you get into these lateral ribs 7 down to 10, ribs 7 to 10, then they're going to be more bucket handle motion, where they're going to come more this way. And they're going to be more on this axis, on an anterior, posterior axis, and moving this way. Now, it's a progression, so you have more pump handle superiorly, and as you go down, even these upper ribs have some bucket handle motion, but primarily pump handle. So what I'm going to do to kind of look at both is have my thumbs, the sides of my thumbs and the pads monitoring the bucket handle, and then I'm coming over lateral. I mean, these will be monitoring pump handle. I'm coming over lateral to monitor bucket handle, and then we'll have her take some deep breaths, and then just blow it all out. And breathe in, and breathe out. Breathe in. And she tends to lag a little bit in exhalation on this left side. Breathe in one more time. And it tends to be more lateral, so there may be a bucket handle inhalation somatic dysfunction here that I need to further address. And then basically come down to the 7th through the 10th rib, 6 through 10, that area, which is going to be mainly bucket handle, but I can have my thumbs over towards the midline to monitor any pump handle motion. We'll have her take some deep breaths. And we'll do one more here. Tends to come in well with exhalation. She lags a little bit on inhalation laterally here, so she's restricted in inhalation, which tells me she may have an exhalation somatic dysfunction in these lower ribs. Now, while she's here, this patient has had some knee surgery, and so we're using some pillows to keep her comfortable. If you remember, we showed that hip flop test. This would be harder for her to do, so in modifying this, I would probably just lift her hip up, and she's had a minor surgery there, so I have to be very cautious. Are you okay there?
Be careful.
Yeah, okay, all right, yeah. And we'll just gently lift that up just to level that pelvis. And so now, if you remember again, we want to look at the levelness of her anterior superior iliac spine. If you remember on our skeleton, we have the posterior superior iliac spine, which we've already shown you here. So now we're going to turn her, and we're looking at her this way, and we're going to come down to the undersling of that. And it looks like your thumb just fits perfectly there, and that's where you want them to be. And you're looking at symmetry, so that if we can see if there's some kind of innominate abnormality. Is this coming out as in a flare? Is it rotating as in an innominate rotation? Is there a shearing force? What has happened in the innominate that we need to address? And if I remember correctly, she had a positive standing flexion on her right. If you look at my thumbs, when I'm in the undersling of that, you can clearly see this thumb is much higher. So I would take those measurements. I would look at the measurements that I took on her PSIS. If her posterior superior iliac spine was inferior, this might tell me she had a posterior rotation of this innominate. If both were high, the PSIS was superior, ASIS was superior, she may have an upslipped innominate there. So this gives me an idea of something that I need to address. Now, with her knees, we know that she's had surgery here with her knees, so we'll have to be careful, but we could also do an eval of her knees if we needed to as well. Okay, also, we've examined her ribs. We've moved down and taken a measurement of her anterior superior iliac spine. Also, you may want to look at her pubic symphysis and see if there's an unevenness there. Now, as we remember in collecting our history, she's had a total knee replacement here, but you can see that she has a valgus deformity of her knee there where that Q angle is a little bit exaggerated, so we can see that. But what I want to do now that she's laying supine is evaluate her hip, and we're going to do that Faber or Patrick test where we flex at the hip, we externally rotate, an abduct, flexion, abduction, external rotation, and then extension, and get an idea. Did you have any discomfort when I did that in here?
No.
Okay. And then we can also just gently place the heel there, and staying away, remember in geriatric, a lot of times we can stir up some discomfort. We already know there's a problem, so I can come to the distal thigh and I'll put a little pressure. Does that cause any problems in your hip, either here or?
Holes in the back, but that's because I just had surgery there
Okay,
2 days ago.
she just had, yeah, she just had a little minor surgery. So if she were to hurt posteriorly, we may have a sacroiliac problem. Maybe she has arthritis, or we've got a sacral torsion or some other problem. If she were hurting more anterior laterally, we may have a femoral acetabular problem. The good thing is we have 2 of these to compare with. So we'll bring this one up. And she has very good hip flexion. So flexion, abduction, external rotation, and extension. Did you have any pain when we did that?
No.
So we're flexing, abduction, external rotation. We'll place her heel right there. Does that cause any problems for you?
A little more pressure pulling than pain.
Okay. Any pain in the back, in the sacroiliac, or any pain up in here?
No.
Okay. And so that gives us an idea of her hips. Remember, hips can be femoral acetabular, they can be sacroiliac, or they could be both. Okay, so we have examined our patient supine, and if we need to do a segmental eval of his cervical spine, we've done so. We've also evaluated his rib cage. Don't forget their diaphragm. And now we just want to get an idea of his quadriceps and knee flexion there. And so you can see that in this case I can flex a little more easily on his right. And then while we're doing that, I can also just dorsiflex his ankles and get an idea of what kind of ankle motion we have. Looks to be fairly symmetrical. He may be a little bit tighter on this side, but it looks to be pretty good if we look at those. So then we can bring these down. The other thing is when you're leveling the pelvis this way so that he lays more symmetrically, you can come up and just bend the knees like when I tested him and bring them down, and that kind of levels him. If we found an abnormality on his seated flexion test, I would then find his crest, fall down to that posterior superior iliac spines, come in at an angle until I get on the sacral sulcus, bring my fingers over to the sacral base, let my thumbs ride down until I get on the inferior lateral angles. Then I can do an assessment of my sacrum and see if we have a sacral torsion, a sacral flexion, a sacral shear, also called unilateral sacral flexion. Do we have something we need to address here? Can come up to his iliac crest, which will bring me around the level of L4. Come out and begin doing an assessment of his lumbar spine. And I can begin doing an assessment of the lumbar spine, get into thoracolumbar, get into more true thoracics, and work my way up to his spine to see if there's anything segmentally that he has a somatic dysfunction that we may need to treat. Okay, and if you remember, she's had a knee replacement, and then she has a valgus deformity of one knee, but we can get an idea of what kind of knee motion she has if we just flex, and this is about as far as we're able to go, and we can see very clearly that she has better motion on her right than her left, but again, we know she's had a surgery there. So we can do that, and then as we come down, I can dorsiflex both ankles and get an idea of her ankle motion, which she's a little bit better here. There is a restriction here, so that gives me an idea to address possibly this talocalcaneal or talotibial, rather, joint. Okay? So if you're wanting to reset the pelvis there, as you come in like this, you can come back, and that will give her a more symmetrical placement of her pelvis on the table. And she's reminded me that she's had a minor surgery over here, so we'll be careful. I'm just going to find her crest, come down, find the posterior superior iliac spines, which are right here, check her sacral sulcus level, then come over medially till I get on the sacral base, and then I just let my thumbs drop and I can get on the inferior lateral angles of this sacrum and get an idea of my sacral diagnosis. If we found problems in her lumbar area, I usually find her crest and I can come do medial, and that gets me around to L4 and get an idea of what L4 is. Then I can go down and get on L5 and get an idea here, and I can clearly see that she is definitely rotating to the right there at L5. She may have a neutral curve in the lumbar spine where it is side bent to the left, rotated to the right, and neutral. And then we can get an idea of her kyphosis, which she does have a little bit of an exaggerated kyphosis, and come up and do the same segmental eval in her thoracic segments. Okay. Now, we may have in geriatrics, we may have a situation where they are wheelchair bound, and so we would want to do as much of our evaluation as we could with them sitting. So again, we would do our same thing. If you notice, she does look like she may have a little bit of valgus on that left knee. We can also see that she has a scar here from a knee replacement. There's quite a bit of varicosities there. She tends to evert her left foot a little bit more than the right, but she has pretty good arches. So it gives me an idea of her lower extremities there. We can see how she's sitting, that she does kind of deviate her head a little bit. Her nasal septum may be a little deviated. And then I can come behind and get an idea of her paired landmarks, as many of them as I'm able to do. And once I have done that, then I can also begin assessing her cervical range of motion. We can go through our rotations as we've done before. Many times you may want to monitor C7 so you don't go beyond that, but I can get an idea of her cervical rotations as we did with her sitting on a table. I can side bend her to each side. She's a little bit tighter that way than this way, so I know we've got a problem here. And then we can also, as I'm monitoring C7, forward bend her and backward bend her and get an idea of that motion. We can also do our side bending that we talked about, where we come in and just check the side bending motion of the upper T-spine group. We can then come in and do the lower group and side bend. Remember, you're bringing your force this way, so I'm getting that lower thoracics, T7 to T12 there. Then we can have her cross her arms in front of her chest here, and we can get an idea of cervical rotation. Of thoracic rotation. Remember, those are coronal oriented. Okay. And then we'll let your arms relax. I can get an idea of her rib motion, having her take some deep breathe in and breathe out. Remember, the upper ribs are primarily pump handles, so I'm assessing that. We'll have her go through 2 or 3 cycles of respiration just real slowly. So I'm looking for a restriction in exhalation or inhalation. And the freedom of motion would name that one. I could also just come down laterally on her lower ribs 7 through 10, 6 through 10, and get an idea of her bucket handle and pump handle. Remember, primarily they are bucket handle in this area. Breathe in and breathe out. So I'm looking at that anterior posterior axis of motion there. So this is how you could modify an evaluation if we had to do one from her in a chair. We could also get an idea of her shoulder motion and have her pronate her hands and bring the back of her hands to each other and get an idea if she has any problems in her upper extremity.